Dr. Tower.
Thank you so much, Pallavi. I think it has been an incredible journey for more than anything else. I think for individuals who have gone through this torment and this crisis of being unwell acutely from COVID, and then facing this very unpredictable future, given the course of this illness and the I would say all the hype surrounding it, all the insecurity and the uncertainty being diagnosed with terminal COVID. We have two great examples of individuals who have fought through this battle valiantly with their families, and they've come out unscathed in some way. At least having the opportunity to live normal lives. Why I thought, and I'm very grateful for both of them and their consent to be on this panel, was issues like COVID require human stories. We need a human angle, and there cannot be a better example or a better testament to that than these two valiant fighters who've come back to normalcy and probably would be sharing some of their thoughts on how they tackled this illness and this period of insecurity that their families went through while they were on a hospital bed hoping to recover. I'm deeply grateful for Kumud having consented to attend this as a panelist. Kumud is much more than what Pallavi described in her brief introduction. Kumud is also credited with having done the world's first organ transplant, that is successfully transplanting a sequence of hearts from circulatory death patients. That is, the heart has stopped beating in all these donors before they were retrieved, reanimated, or brought back to life, and then transplanted successfully in patients with end-stage heart failure. Kumud is one of the people that I have always looked up to in the field. It's a great pleasure and honor to have him with me on this panel. As far as Urmil is concerned, Urmil is a very young, passionate, and a very talented pulmonologist. His entire focus is transplant pulmonology. He gave up his entire interest in interventional and regular pulmonology when he diverted his complete attention towards transplant pulmonology. He has been a true pillar for our service, and what we have achieved in treating many patients like both Pranav and Ravi, a great deal of that goes to people like Urmil and the rest of the team. I am very grateful to MOHAN Foundation for having picked up this topic, and Pallavi especially, because in our discussions we thought about how we could bring across all these great scientific minds, Kumud, Urmil, and many others in the community to make or decipher all the complex questions and the decisions that many patients and their families have to make in these times of crisis. So with that, I'll open this forum. And my first question would obviously be to Kumud. And I would like to ask you, Kumud, is how would you unpack all of this? How would you begin to unpack all of this complexity for largely our audience being donor coordinators, transplant coordinators, people who are first responders to many families that have questions when they have been told by local teams and local physicians that, your son, your brother, your father has terminal COVID. It's a terrible problem. We don't see the lung improving. He needs a lung transplant. I mean, the solution is directly a lung transplant, right from being on a ventilator. There is no other solution, especially in a country like India, where lung transplants were unheard of a year ago. They're obviously right up there in the center spotlight, and it's a very difficult process for many of these coordinators to unpack and unravel or probably even explain. So would you please give us some idea on how you would approach this? Kumud, you have to unmute yourself, Kumud.
Pallavi started in an introduction saying exactly that the problem was for them facing questions to which they did not have answers. And in fact, we in the clinical community have not been terribly good at giving that information out. And it remains very institute dependent. There is no proper guidelines that have been written in India for the local community. If anything, the guidelines that come from abroad, particularly, for example, a 10-point guideline on what to do about lung transplantation post-COVID from the Toronto group. The ISHLT, the International Heart and Lung Transplant Society, regularly updates its own advice on what to do with thoracic solid organ transplantation. So the first thing to address is this issue that you mentioned about what should we do with this advice that our patient, our nearest and dearest, our loved one needs a lung transplant. And that's where the problem starts. I think we're overselling hope. I think we have an environment of false hope. We need to be far more realistic. And what that is that the relative is now come to the end of normal standard of care of even ventilatory support. And they may or may not have been instituted on ECMO therapy. The subsequent transfer to a higher level center, either for ECMO or a consideration of lung transplant, should not be one of sending for a lung transplant. It's transferals for continuity of care at a higher level center. It may or may not eventuate in a lung transplant, because until you or I or our equivalent colleagues have seen the patient eye to eye, examine them thoroughly, you will not know they're fit for transplant. And there are a host of relatives who believe that this transfer is going to result in a lung transplant, and often it does not. Even the ECMO bridge is not for a day or two, unlike other temporary organ failure, putting a, let's say, ECMO for a heart problem or an isolated lung problem. And it is so different from the ECMO requirements that we faced a few years ago, now going back, 2009 with H1N1, where they did well with ECMO and survived. Now the ECMO for COVID is required for 3-4 weeks or beyond. And some are beyond 6 weeks or even longer. And you've got a wonderful series of very prolonged ECMO supports, which you've successfully transplanted. But those are very, very few that have done well in the context of the overwhelming workload that is coming our way. And so we have to be realistic. I think we need to be truthful. We need to say there's far more assessment that needs to be done at a higher tertiary level. And that has implications for whether or not you transfer. Are they in a fit state to be transferred? Are they beyond salvage for a lung transplant? Now, this is a real conflict, because the relatives will grasp at even a 1% chance of survival for their loved ones. But that 1% does not translate well into a hopeful future, when in fact, even if you and I do a successful transplant, their stay in hospital is so prolonged for rehabilitation that in the Indian context, the risk of infection is so high, the chance of ever getting home in a state that they would wish to be home, and in the state to enjoy their life at home, and in the state to interact with their loved ones at home, is highly, highly unlikely. And so we just have to be honest. We all have to have the same story, so that Pallavi and her colleagues have a simple set of answers that they can give, that for which there will not be a conflict between yours, mine, other units across India.
Great. Thank you, Kumud.